please. So Gillian's going to talk to us about the primary care networks and the progress they've been making on identifying health inequality priorities.
Thanks, Christine. So I'm Gillian. I'm the head of PCN Development and Partnerships for Herefordshire. What I want to run through today is just a bit of the work that we're doing for primary care networks, looking at health inequalities or tackling neighbourhood inequalities as our PCN contract requires us to do. So I'll just give you a bit of an outline, and I'll come on to later probably the important part for us today, which is what each of the networks are really starting to do around this. So each of the PCNs are using their data at the moment to understand the populations within each of their networks, inequalities to health provision. So that could be a provision and or outcomes. Connor at the back there, we're going over the data later, but we've got quite a rich source of data from EMIS, from our patient population. We recognise there are gaps in this, though, which probably some of you all here are aware of today. So I think it's really important as we develop these conversations that we build the links with yourselves to start to feed in what you're seeing, those that unmet need, the patients that we're not seeing in general practice. What we need to then do is engage with our identified cohort to understand the gaps and the barriers to their care. So really listen to those people with lived experience to understand how we can change our approach to delivering care. As I've said, we want to work with you all to understand the unmet needs and work together on some of the solutions. I don't think any one of us have got the whole solution to any of it. So how can we work collectively across organisations as a true PCN partnership working to meet some of those needs? It's really important that we look at how we measure the impact and the outcomes. And as Matt said earlier, some of those are really long term. Some of them are shorter term, just actually have we improved that patient's confidence to manage their own health and well-being, but some of them are much more long-term outcomes that we need to start measuring now to see how we do in 5 years, 10 years against those. It's still really early days for these, so just bear that in mind when we go through the slides. We've only just started these conversations in the last few weeks, month. We were in the really early stage of development, again, which is why I want to come and talk to you here. And it was picked up at the last session that actually there's opportunities now to look at what difference everybody can make, do some of that doing. We're really looking at early prevention and intervention. We've got developing wellbeing teams, we've got some new roles, we've got social prescribing, we've got talk community, we've got the healthy lifestyle trainers. How can we all work together to look at that preventative support for our patients? And just a little bit about the governance. So the PCNs are required to report bi-monthly to the ICS, the integrated care system around this. So there's an inequalities prevention and collaboration partnership. So we are required to report there, and they will challenge us and pick up if they think there's gaps that we could be doing better on as well. So what we're looking at the moment is developing how we can look towards that partnership working. So that's engaging with our population, engaging with statutory bodies, so all organisations in that network, VCC and businesses. We really need to include the views of the people with lived experience. It is a new way of working for general practice. We do it in parts. We probably aren't as good as we could be. So we have some learning to do, and we're looking to some of those that are better, such as public health. There are people in the system that have done this before, and really looking and learning about how we can do this better. We'll be working collaboratively with everybody. We've got a Herefordshire Health and Quality group, and we're looking at using that forum as an opportunity to develop some of these approaches to make sure that we've got that working robustly in the networks. We're looking at innovation and transformation, so different ways of working. This isn't just delivering, again, more patient appointments. Actually, can we do more walk and talk? When we're doing walks and talks, can we put some of our health coaches out there? Can we do other things? We've got things that are already in place, but actually how can we build on those? I've already covered the data sharing and monitoring, but it's that real cohesion. I think at the moment, as I touched on, we've got general practice data, we may have some secondary care data, we know public health data, but actually, what are you all hearing from people that you will see that maybe we're missing and we need to know about as well? So how do we start to work together to pull all of that data into one view that our PCNs can review and actually understand what can we do better, what are the gaps, what do we need to escalate to look at the system to change the way we deliver services, and then to share the learning across all of the PCNs. Every PCN, the beauty of it is every PCN can do something different. They have different population health needs, but actually what one PCN does, the next might say, actually, that was really good. That was actually quite simple. let's just replicate that in our network, and then we can maximise on what everybody's learning is. So I think there's probably some quite exciting things to come in the next year or so, but the important is we'll talk about it and share that conversation together. I won't go through this, but I just want to pop this slide on here just to show how simple this can be. We don't want to over-engineer this at the start. This is a new way of working for us, so we need to keep this simple. Pick a small cohort of patients with unmet need, and look at how we can put an intervention in there and support them much better. So I'll go through the different focus areas we've got at the moment. So over winter, all of the PCNs focused on health inequalities around their COVID vaccinations. And as a result of that, we do have one of the highest uptakes of vaccinations in the country, particularly in January. I think we were the highest county in England for COVID vaccinations. Recently, NHS England got in touch with us to ask us how we did so well at targeting some of those areas of deprivation, some of the lowest uptake areas, some of those children immunosuppressed, see what we'd done that was different so they could share that learning. And to be honest with you, I don't think we did anything particularly clever. We just spoke to one another and shared the learning. So general practice didn't do it in isolation. We worked with Wye Valley Trust, we worked with public health, we worked with the commissioners, we worked with community leaders, and that was the beauty of it. With the public health links, they can talk to the community leaders, feedback to us what works best. We realised we needed to get a roving van, go out into communities, and that's what's made a difference. And I think that was quite powerful. The learning from that has taught us an awful lot about actually the difference between just getting broadly into somebody's area and getting to the end of their street to get that uptake rate. And it's something that we're now looking to roll out across our annual health checks and keep that roving approach to really keep up that impact in those areas of deprivation. So that brings me on to the next part. So the PCNs are now looking at how we can change the delivery of health checks. They'll still be available at GP practices because a lot of people like to access those services there, but actually can we get out into farmers markets? Can we get outside Tesco's to do health checks? There are other ways of working, but while we're doing that, let's make every contact count. Can we talk community with us, healthy lifestyle trainers, health coaches, and have a conversation with people at the same time as well, because often they may not have anything that picked up on their health checks, but we can let them know about walking a bit more or getting slightly more active, what's in their community. So as I said, all the networks are looking at the moment. We're also looking at other specific focus areas for each network. And this is where it's important to remember it's early days and we're keeping simple. So in the East PCN, they're looking at reducing obesity. And this is a theme that's been picked up by most of the networks that we need to tackle. So they're looking at those patients with a BMI of 30 or over, depression, not received a COVID vaccination. They're setting up a project group at the moment. So I'd expect Amy with Talk Community, a conversation with your community action networks to start to explore what we can do about that and understand from that cohort maybe why they didn't take up that COVID vaccination or what we can do to support them with losing a bit of weight and that preventative area. Hereford Medical Group are looking at patients affected with childhood adverse experiences. It's a hard cohort to look at if you just try and search on our GP records to find those patients. It has been done in other areas. So the key thing for them will be to start finding those patients and actually starting to talk to them and understanding what we can do. It's about improving staff awareness, so some of that trauma-informed care training. There's some wellbeing training as well linked to trauma-informed care, which has been really well received by our staff. And again, working with VCSE to look at ways we can develop and improve those health outcomes. The South and West have just had a change of development manager and a clinical director coming in. So they are just regrouping and getting together a team to start looking at their data and their health and equality focus. They are really looking at the moment at their health checks and how we can get more mobile, but I'd expect the South very soon to be looking at another focused area as well. So I'm sure with Clover, with some of the other groups in the south of their county, we'll be looking to engage fairly soon around that. The North, again, looking at reducing obesity, but they're looking at two cohorts, both BMI 30 and over, one fibromyalgia, loneliness and isolation, and they're setting up group consultations. So patients will have a choice of them being face-to-face or online. We've really found that those video group consultations work well for those that may be more isolated or a bit more anxious. They can do that in their own home, but others really like to have that in person. And that could be, again, at a Talk Community Hub, it could be in the library, it could be at Halo. And we're going to take them through a 5-session programme. And for me on this, it'd be really interesting to understand from some of the organisations here and within the network, where there's an opportunity to joint run one of those sessions as well. So we can link those patients into what's in the community. We're also going to be working with the healthy lifestyle trainers, I hope, to be looking at those patients with pre-diabetes and anxiety. And these are those patients that possibly aren't engaging with the National Diabetes Prevention Programme, to understand what those barriers are, to improve through motivational change and lifestyle behaviour change, to improve their engagement with those other services. We're not looking to replace what's already available, but we're looking to support those patients to engage with what is there currently. They're looking at their housebound patients. So we have 2 paramedics in the north of the county who work with general practice and provide a roving home visiting service. So looking at those housebound patients that we've not had any contact from for a year, to see, just to check in on them and see how they are, because it could be in some cases people aren't wanting to contact us because they know general practice is busy, they're anxious. So let's get proactive and go and see them and see how they're doing. Also, when you walk in somebody's house, you get a different feel for what's going on, and some of those other teams like social prescribers and coaches, again, we can start to engage them in. And then we'd like to explore through the North and West community action meetings, working with VCSE for yourselves to identify the things. What are you hearing that patients might want to talk to us about? And then can we put on some group consultations, pull in some expert speakers to actually talk to people? So it could be that we need a session on fuel poverty. What can you access? How can you access that? And we can do that with multiple people at once. And often we find it's really powerful that they share their learning with one another. And often they'll listen to one another a lot more than the professionals. It's really quite powerful. So we're looking at that as well. WBC are looking at 2 areas, so learning disability and those that are harder to reach, specifically the non-attenders. So looking at that Learning Disabilities Week, can we do more around the health assessments and offering listening services, and also around those non-attenders, it's getting out into the community again, looking at that visiting food van on the Fridays, looking at the health assessments there, and raising awareness and screening opportunities. So I think that's a really positive change to how we're looking to engage with our populations. And then finally, I just want to touch on this. It is slightly separate, but I think possibly the 2 things are very closely aligned and likely the same cohorts. PCNs by the end of September also need to work with everybody to identify a cohort of patients with unmet needs. And it's likely that they could be, in our health and equality cohorts as well, and look to offer proactive social prescribing for that area. This isn't for discussion today per se. We'd like to bring it back and talk to you all about it in a lot more detail. But as we go through the conversations later, I think there probably are those very close links with the health inequalities. So if there's an obvious link, then let's build that in now and start to test out, can we do some proactive social prescribing with those groups? So that's a quick run through from me. I'm happy to take any questions if there are any.
Marcus?
I'm not trying to grab it, honestly. It's all very well to say, we're going to do this, we're going to do that. You're finding GP practices so busy now that people are just staying away. They just don't want to go because they know it's so busy. We run a dementia coffee morning once a month. We used to have a nurse come to advise people of all sorts of things. That stopped. Nothing's taken its place, and nothing is planned to take its place as far as I can see. That's just withdrawing stuff from people. So I'd just like to know how you're going to do what you say you're going to do.
It's a good challenge, and you're right, we are busy. We are seeing more patients than we were previously, but we have got new different team members coming in, so it's not just come and see your GP. It's about that whole range of services, so social prescribers, health and wellbeing coaches, care coordinators. It's about how we can work with other people as well, healthy lifestyle trainers. We aren't trying to do this one alone. And it doesn't actually have to be in GP practices because they are very short on space with all the additional roles they've got now. So actually, what can we bring out in the community and do there? Sometimes that medical model, if it's for a social need, isn't the best fit. But I do take your point. We need to get that balance right. We need to listen. And yeah, I think a lot's going to change over the next 12 months, but we just need to do that together.